Morning, everyone. Now I'm going to discuss the MCQs paper, August 2018. Uh, so um, so the first question here: you start a patient on levothyroxine. So the patient started on levothyroxine, 100 microgram daily for newly diagnosed hypothyroidism. The indication is hypothyroidism. When the most appropriate time to repeat her thyroid function blood test with a view to adjust her dose of levothyroxine. Usually we have to wait 4 to 5 half-life of thyroxine. The half-life of thyroxine it is 5 to 7 days. So 4 to 5 half-life of thyroxine it's gonna be 6 weeks. So the most appropriate answer here it is 6 weeks. So after 6 weeks you have to repeat the thyroid function test to either to continue on the same dose or if you would like to do adjustment if the thyroid function test came back abnormal. So question number 2, 30-year woman presents with a severe occipital headache that started suddenly that morning. So here we have a young age female presented with severe occipital headache that is started suddenly. So sudden severe occipital headache. She has never had headache like this before. This characteristic statement is called worst headache in my life. So this is very characteristic, and we have to one of the top of the differential diagnosis. It has to be spontaneous ruptured subarachnoid hemorrhage (SAH). So she won't allow you to turn the examination light in the hair cubic because she had some sort of photophobia and it hurt my eyes. She said it hurts my eyes. So she had some sort of photophobia. So which of the following investigation will you arrange first? So this lady is highly suspected to have ruptured rub, ruptured subarachnoid subarachnoid rupture subarachnoid or subarachnoid hemorrhage or ruptured AV could be AV malformation leading to subarachnoid hemorrhage. So the most likely it is SAH subarachnoid hemorrhage. It should be on the top of the list of our list in the differential diagnosis. Which of the following investigation will you arrange first? Blood culture or chest X-ray or CT brain or CT facial bones or lumbar puncture. So the most appropriate to arrange for you have to do brain imaging, especially CT brain, because CT brain is very sensitive for intracranial hemorrhage. So the CT brain has to be done as soon as possible for this lady. And the top of our differential here, it is ruptured perianeurysm and spontaneous subarachnoid hemorrhage. So let's move on to question number 3. 5 patients have presented to acute medical unit, AMU, with chest pain at the same time. So all they have chest pain. You assess the risk of having adverse outcome so that you can decide which patient to treat most urgently. So he's asking you to do triage for this patient, which patient has highest adverse outcome, and if the patient who will have the highest adverse outcome will need urgent review. So which of the following patient has highest risk having major cardiac event in the next 30 days? So here we have multiple scores and scales used in the emergency department for calculation of what is called adverse cardiac event. Adverse cardiac event is called. One of these, it's called heart score. It's called heart score. It calculates major adverse. It calculates. This is major. I'm sorry. Here, I'd like to take just comment here. So it calculates the here major MACE. MACE. It is major adverse cardiac event in the next 6 weeks. So according to this score, heart score, H, it is in the heart, it's history. E, it is ECG finding. A, it is age of the patient. R, it is risk factors. T, it is troponin level. So in this question, they are not mentioning the troponin level, but they are mentioning the history of the patient. They are mentioning the ECG finding in the each answer in each part of the answers, and age. They are mentioning the age of the patient and risk factor as well. So we have to calculate the heart score for the patient. If the heart score is 0 to 3, so it is 2.5% major adverse cardiac event over the next 6 weeks, and usually they need, it's safe to discharge them home. If the heart score is 4 to 6, it is 20.3% major adverse cardiac event over the next 6 weeks, and they need admit for clinical observation. They need admission to hospital and observation. If the score 7 and above, up to 10, because the maximum point is 10 of this score. If it is above 7, so it is 72%, 72.7% major adverse cardiac event over the next 6 weeks, and these usually they need early invasive strategy. Either it's a primary PCI, which is the gold standard, or sometimes they might be candidate for thrombolytic therapy. So let's go back to our question here. So here we have 60-year-old. 60-year-old, it will take 1 point. With left-sided chest pain. Left-sided chest pain, it will take 1 point because it is not a typical cardiac chest pain. Typical cardiac chest pain is going to be retrosternal chest pain. Left-side chest pain, it is going to be 1 point. She has a history of dyslipidemia. So dyslipidemia will take 1 point. ECG findings show T-wave inversion in the lead to 3 AVF. This is going to be T-wave inversion as well. I think it's going to be 1 point. So the total for this lady, it is 1, 2, 3, 4. It's 4 points. So if we are calculating for example, for the D and E, here 75 years old, it's 2 points. And central heavy chest pain, it's 2 points. And she has a history of hypertension, dyslipidemia, and type 2 diabetes mellitus. This is 2 points. And so because she has multiple comorbidities, and the ECG findings show ST depression in the lateral leads. ST depression is according to this score, which is heart score. The ECG finding significant ST depression, it's considered to be 2 points. So this lady, it's going to be 2 points for the ST depression. So if we are calculating, it's going to be it is 8 points, the total of 8 points. Here in the choice E, we have 77. It's going to be 2 points. Central pleuritic chest pain. So central pleuritic chest pain, I think it is not a typical cardiac chest pain. So I think it's going to be 1 point. History of hypertension and dyslipidemia, only 2 comorbidities. It will take 1 point. And ECG show upward ST elevation, it's going to be 2 points. So if we are calculating for the E, 2 and 2, it's 4, and 5 and 6. So in total, it's 6. So I think the correct answer here, it is D. This is this patient or this lady, she will have the highest risk of adverse or major cardiac adverse event in the next 6 weeks. And he is asking specifically about the major cardiac event in the next 30 days. So I think it is answer D. The answer is either will be D or E, but I think it's D. It's the most appropriate answer here. So question 4, 38-year-old woman with newly diagnosed breast lump. So here we have a new diagnosis of breast lump. It's seen in the clinic following her surgery. After the surgery, it has been recommended following multidisciplinary team discussion that she should be commenced in the endocrine therapy. So here we are starting endocrine therapy for breast lump. Usually we are removing the breast lump and we are sending the breast lump for histopathology. And according to the finding of histopathology, they will classify if the patient, for example, has breast cancer, they will classify the breast cancer into the ER receptor positive or ER receptor negative. ER and PR. PR, it's progesterone receptor. PR, it's progesterone receptor. Either it's going to be positive or it's going to be negative. And the other things here, it is the HER2 new human epidermal receptor, HER2 new receptor. Either it's going to be positive or negative. So according to this finding, we will decide what's new adjuvant therapy or what's new adjuvant therapy we can use. As in the multidisciplinary team discussion, the decision was made to start her on endocrine therapy. So this means that she has progesterone and estrogen receptor positive breast cancer. So the most suitable endocrine therapy for this lady, I think it's going to be anti-estrogenic therapy or selective estrogen receptor modulator, SERM. So it's going to be tamoxifen. So here, the tamoxifen, it is the most appropriate. If the question was regarding breast cancer with HER2 new receptor positive, so the answer is going to be trastuzumab. So this is I think the question number 4. Question number 5, a 74-year-old lady presents with 20-year history of right upper quadrant pain. So right upper quadrant pain. She has now developed nausea and vomiting and abdominal distension. Her heart rate is 80, blood pressure 150/90, and she is apyrexial. Plain film abdominal shows distended small bowel and air in the biliary tree. So presence of distended small bowel with this clinical picture is consists with small bowel obstruction, and presence of air in the biliary tree, it's called pneumobilia, consists with presence of cholecystoduodenal fistula, and this fistula lead to this pneumobilia. So the most likely it is gallstone ileus. So the patient has gallstone ileus. What is that? Her definitive management is it appendectomy or cholecystectomy or colonoscopy or enterotomy with stone removal or intravenous antibiotic? The most appropriate treatment here, enterotomy with stone removal. So you have to do laparotomy and you have to open the small bowel, most likely site of impaction of the stone in the terminal ileum. And you have to open the small bowel and remove the stone. This is the most appropriate treatment or the definitive management. So the question number 6 I will discuss in the next video. So all of these videos and the previous and coming videos, it's going to be on my Teachable.com platform. I would like to thank you for joining us and for watching all of our discussion here for preparation for final 3MB medical students. Thank you.